Hi, everyone. I'm hoping I'm live. New platform. Thanks for joining that breakout session. My name is Alexandra Rutishauser. I'm the head of nutrition for Action Against Hunger UK, and I've been delighted to ask to facilitate this session because we have really great speakers. And I'm also glad to have some French and English exercises for me in the station. So I will start this presentation. We'll give it a few minutes just to make sure that everybody arrives on time. And they miss my name. I'm sure it's fine. Everybody, you don't need to know exactly who I am. The most important are, I think we can start now, are the two first presenters of the first session. So we have Jeanette Bailey. She is a nutrition research and innovation lead for the International Rescue Committee, and she is still the principal investigator for the COMPASS study. And she will share this presentation with Suvi, who is the International Rescue Committee, Nutrition Research Coordinator for West and Central Africa. And so together they will tell us about combined protocol and the practical implication for scale up. So over to you, Janet, if you can share your screen. Thank you.
One moment, everyone. I'm just pulling up the presentation to share.
Yeah, so while you do that, just saying that we have Janet and Suvi will present in English, and then the next presenter will be in French. So translation is available. You can see how to do it in the chat box.
Okay, so I assume everybody can hear me. You can hear me, Alexandra?
Yes, yes. Okay. Be a little bit louder, but it's okay.
Okay, I'm going to have to yell because my laptop is apparently very muted today. Hi, everyone. It is early in the morning in the United States on the East Coast. So I'm happy to be able to share some of the International Rescue Committee's experience implementing a simplified and combined treatment protocol. We'll be looking at some results from our RCT and our programmatic experience. And my colleague Suvi will then share the case study from our Mali country program in terms of the implications for bringing this protocol to scale. So the simplified combined protocol that we tested in COMPASS, it looks like this. This slide is really busy, so I'll just talk you through this. It's really a very simple protocol. It's based on a couple key ideas. One being it's a combined protocol, so it's SAM and MAM combined in one protocol. And the other is that it's simple. So it's based on MUAC and edema only. So you can see this algorithm on the right. That's based on basically if a child has edema, as you know, they're classified as SAM. And depending on their MUAC category, if we've got a SAM MUAC less than 115, they get 2 sachets of ready-to-use food per day. And if they've got a MAM MUAC 115 to 125, they get 1 sachet of ready-to-use food a day. We use ready-to-use therapeutic food, RUTF, in the COMPASS trial, and that's also what we're doing in all of our operational trials. So, really, I think the important message here is that it's both a combined SAM-MAM and a very simple MUAC-based protocol. And COMPASS was the first RCT that we know of to test a MUAC-based dosage. As you know, most dosage protocols are based on weight during the SAM period. This was quite unique in that we're looking only at MUAC. And the reason we wanted to develop a protocol that was MUAC-based is because it's easier. It allows the potential for community health workers at the village level to implement this protocol. IRC has actually developed a toolkit along with our partners with a simplified MUAC, a non-numeric weighing scale, a word-based registration book. And so when you look at a really simple protocol like that, the goal is to increase the coverage of care, the availability of care, and access to care. And the other goal is to make it more cost effective, because if the more we can simplify this and make sure the dosage is optimal, the goal is that we reach more children that way for a similar amount of resources. So the COMPASS RCT was in Kenya and South Sudan. We had about 4,000 children enrolled in this trial. We had 24 clusters, so it was a cluster randomized control trial. And we had two main outcomes, two main results. One is that we saw non-inferior recovery in the combined protocol compared to the standard. And the other was that this protocol was more cost effective in the RCT. So in terms of recovery, we found about 76% of children on the combined protocol and about 74% on the standard protocol recovered. And the deaths were about equal across the two treatment arms. And the median time to recovery was also exactly equal, around 10 weeks in both. And in terms of cost effectiveness, we found that the amount of ready-to-use food required for a child with SAM, a child admitted with SAM, to reach full recovery, meaning they no longer have MAM, it was less in the COMPASS protocol, 122 sachets in the combined protocol, 193 sachets in the standard. And the COMPASS protocol was less, $123 less per child recovered. You see the total amounts were very high. That's because this was an RCT. We invested a lot of resources in the trial, making sure that the standard protocol and the combined protocol were equally supported, and with a lot of oversight that you wouldn't normally see in a normal program. So the next step after we finished the RCT was to generate evidence in operational settings. And that's what we've been doing the last 3 years, since 2018. It started in West Africa, in Mali and Chad, in partnership with UNICEF and WFP and funded by ECHO. And we've since expanded, and now we're doing pilots in Kenya, South Sudan. Sorry, we're not doing South Sudan. Kenya, Somalia, Mali, Chad, Central African Republic. We've got a really large database of, I think, around 35 to 40,000 children who've been treated now with this simplified combined protocol. And in addition to what IRC is doing, I mean, this list right here on the screen is IRC programming. In addition to what IRC has been doing, we're also aware of at least 6 other NGOs who are also using the protocol that we tested in COMPASS, the simplified protocol from COMPASS, in about 13 countries. So we have Action Against Hunger in this panel. We have Alima. I'm also aware of MSF and Save the Children and Concern and Goal, perhaps also using this in different locations. So I think that they can also speak to their experience, but there's, I think, about 7 NGOs now using this, which is good. It means we're going to get more evidence from a diverse range of operational experiences to really help us understand what works where and how this protocol works in different contexts. So the preliminary findings from our operational pilots, this is a quick snapshot that we looked at about a month ago, and the database keeps growing. So from about 20,000 kids who have completed treatment, we've seen very high recovery, 85 to 95%, low mortality and low defaulting. The length of stay has been good, about 8 weeks for children who enter with a MUAC less than 115, and 5 to 6 weeks for children with a MUAC between 115 and 125. Average daily weight gains have been very good, 5 to 6 grams per kilo per day. And we're also seeing high recovery in some vulnerable subgroups. And this is of particular interest to us. We want to make sure that this protocol isn't just effective overall, but also really works for the children who are the most vulnerable. And I think this is where we need more research. And I am aware of Action Against Hunger, Alima, and IRC are now doing RCTs specifically to look at how this protocol works in children with SAM, for example, or children with concurrent wasting stunting. But we've seen high recovery in our database among these groups of greater than 80%. So I will now pass to my colleague, Suvi, who is going to speak specifically about our experience in Mali.
Okay, thanks, Jeanette. So I would like to take you through some lessons learned from implementing the Compass Simplified protocol in Mali since 2 years, and the next steps for thinking of scaling up this approach. So we prepared this presentation together with the MOH representative, but who did not wish to speak in English. So I'm hoping to do justice to our discussions and as he's listening in. So in Mali, IRC has been supporting the MOH in piloting the Compass protocol in one district since December 2018. And in addition to the protocol itself, we've also rolled out the treatment delivery at the community health worker level, and also scaled out the family MUAC approach in the district. Now, first, why do we think that Mali was and is an ideal context for this protocol? We could think of 4 reasons. So firstly, in Mali, there is an existing strong community mobilization with community health workers and volunteers engaged in sensitization and screening of children. So this is really key to tapping into the MUAC screening and referral that this protocol really emphasizes. Secondly, we really rely on the MUAC screening in Mali for treatment seeking, as there's no effective growth monitoring happening that would enable a regular contact for children at the health facility and measurement of their weight and height. So we really rely in any case on MUAC for the treatment seeking. Then thirdly, there is an existing community health worker treatment policy in place in Mali, but that has not yet been rolled out, meaning that we really have an opportunity to train this workforce on the new, much more simple protocol from the start. And then fourth, there is a very low CMAM treatment coverage and availability of the inputs, which means that the simplified protocol can really increase the treatment coverage in this area. Slide, please. So what have we achieved until now in this district? We've got over 19,000 admissions so far, out of which 38% were admitted with MUAC less than 115. We have a very high recovery rate, so 96% overall, and even among the MUAC less than 115, a recovery rate of 93%. The length of stay is around 2 months for those children admitted with the MUAC less than 115, and around 1 month for the MUAC between 115 and 124 at admission. And the RUT of consumption is much less than a regular standard protocol, so 88 sachets for those admitted with MUAC less than 115, and 38 sachets for those admitted with MUAC between 115 and 124. And this is when including the discharge ratio of 7 sachets at discharge. Slide, please. So then we try to think of potential barriers and boosters for next steps when going to scale, if going to scale. Now, firstly, there has been a recent protocol revision in Mali in 2018, I believe, and that was seen as a potential barrier in the sense that there might be a reluctancy of engaging again very quickly in a new protocol revision. There's also a lack of clear cost data, data that could compare the cost of rolling this out, and that would also include the time, use, and HR resources that would potentially be needed more or less when using this new protocol. So there's no good cost data yet. There's also a lack of experience from urban context with implementing this protocol. And the fact that there are, in Mali, there are several adaptations being tested in the same context. So this can be both seen as a barrier and a booster. A barrier in the sense that it could create confusion with a lot of different things going on, and so not knowing which one should then be taken forward. And on the other hand, that we also put it in the boosters in the sense that it can be used as a leverage for actually policy engagement and debate for thinking which protocol, which innovation, adaptation should then be brought forward. And finally, the potential barrier of RUTF availability and pipeline. So per individual, per patient, there is a less RUTF needed, but as a total, the RUTF needs are increased with the simplified protocol. It seems they are increased, and so there's a need to look into that and also see through who we can work with the pipeline. So a sub question here in the Malian context, where the government really wants to start budgeting for the RUTF, then if there is an increased need for this commodity, then how can that be still made available and budgeted through the government? Now in the boosters, we've clearly seen that there is a high acceptance of the new protocol from the healthcare staff. So they really find it much more simple to use, both for admissions, but also for following up the children and their recovery, with only the MUAC being used and looked at, and also the prescription of the dosage is much simpler for them. And this also means that the supervisions have been much to and easy to do. UNICEF and MOH are very engaged in Mali in these simplified pilots and approaches, so that is obviously a very important facilitator. Again, as said, the other adaptations and pilots are ongoing, and this can really be used as a leverage for policy debate, we believe. There's really good coordination between UNICEF and WFP in country, so this is obviously very important. And also a good alignment of the major RUTF funders behind this new approach. Slide, please. So now thinking of if this new protocol is then introduced as a new protocol, so the protocol goes through a revision and this comes through, what would be the practical implications for the government? Now, what we've seen, obviously, the first point is about the inputs. There would be a need to calculate the needs. Then secondly, the training. So who will be training the whole health workforce on this new approach, and how should this training be made? In our pilot, we trained the district, or the whole health workforce of the district, both in theory, but then also 2 days in practice in each health facility, so that the healthcare workers really felt confident with this new approach and how to administer care, but also how to note down the registries, etc. And then lastly, but importantly, there's a possible need for reorganization of the CMAM days. So what we saw in our pilot is that indeed the simplified protocol did increase the patient caseload, which in certain cases meant that the health centers needed to reorganize and split their CMAM days into 2 in order to provide quality care to all the children that now needed it. Slide, please. So just my final slide to talk about some priority actions that we're planning on taking in Mali to address those potential barriers. So we do believe that there is a need to keep sharing the evidence that is produced on these new approaches and to follow the WHO guideline revision in order to see whether there is still a need for protocol revision. We are producing rigorous costing data from our pilot, so including the time use of the healthcare staff and also the opportunity and time use cost of the caregivers. this is coming soon. There is another pilot that is producing, that it has been done in an urban context, so that will be producing results on this, hopefully filling that lack of data. And we also do hope to engage the national level simplified approaches steering committee in more policy debates, so that this group can be really used as a leverage and as a guidance group for any policy revisions. And finally, we are also supporting the development of a resource estimation tool for the RUTF needs during simplified protocols. So I think that's all for me. Next, I would just like to thank everyone, and I will leave you with a final slide on some of the resources you can look into more closely concerning the Compass trial and the results produced. Thank you.
Thank you very much, Jeanette and Sylvie, for your presentation. Also sharp on time, very much appreciated. Really sorry about the problem with the echo. Looks like some participants managed to solve it on their own, but turning off the mic on the conference page, I can't do much on my side, but they're looking into it. Hope you can hear me well, although. Just to remind you that we will take questions after the two presentations. So do not hesitate, please, to include your question. I already see one coming. I've looked at the list of attendees. I know a lot of you, I'm sure a lot of you will have questions. So please populate your questions in the question and answer box. So thanks again to our previous presenters. We'll hear from them in the Q&A session. Now we'll introduce you to our third presenter today. His camera is on and off, so you might see him or not. He might remain a mystery. Dr. Alitanou Rodrigue is the medical coordinator of ALIMA. He is working on a platform called CORAL, which stands for Clinical and Operational Research Alliance, which is an alliance between ALIMA and the INSERN Institute. And he will tell us today, talk to us about Optima, which is a project looking again at simplifying the treatment of acute malnutrition. He had some issues with sharing his screen, so I will have to be the one sharing his slides. Dr. Alitanou, can you hear us?
Oui, on peut aller.
Okay. Perfect.
Bonjour à tous et à toutes. Je prends la suite pour vous présenter la stratégie Optima qui désigne l'optimisation du traitement de la malnutrition aiguë. Donc, il s'agit de la stratégie mise au point par la plateforme CORAL, donc dans la dynamique de développement des protocoles simplifiés. Slide. Pourquoi Optima? Slide, Jeanette.
Oui, oui, normalement, enfin, ça a changé chez moi.
Ah, d'accord, bon, on y va alors. Parce que je l'ai aussi devant moi. Donc, Optima a été développé dans le cadre du contournement des limites opérationnelles que rencontrent les programmes de prise en charge de malnutrition dans la mise en œuvre, ainsi que les conséquences que ces limites engendrent sur la morbidité liée à cette pathologie. Alors, quelles sont ces limites? C'est d'abord le retard de dépistage, de la prise en charge et de la prise en charge précoce, qui sont souvent ont des conséquences sur le développement des complications avec des risques très élevés d'hospitalisation en soins intensifs et des risques de décès aussi élevés. Il faut dire aussi que ces limites résident également dans la complexité des définitions de la malnutrition du fait de l'utilisation de combinaisons nécessitant des moyens humains non négligeables, également du matériel fiable. On note aussi un intrant thérapeutique et le croisonnement de la prise en charge des MAM et des masses qui complexifie davantage la stratégie. Par ailleurs, Il faut souligner aussi que la faiblesse des couvertures est de normes et que le secteur est également en sous-financement à ce jour du fait de son caractère d'urgence de plus en plus chronique. Slide. La stratégie Optima propose 3 changements stratégiques. D'abord, l'utilisation du périmètre brachial, aussi bien par les familles que par les prestataires de soins, dans la surveillance nutritionnelle et le dépistage des enfants de 6 à 9 mois, ainsi que leur monitorage au cours du suivi et de la sortie du programme, le tout associé à la recherche des œdèmes. L'utilisation d'un seul aliment thérapeutique pour tous les enfants souffrant de malnutrition aiguë. Donc, ceci semble donner une cohérence des programmes de prise en charge de la malnutrition. Et enfin, la réduction du dosage d'aliments thérapeutiques en fonction de la récupération nutritionnelle de l'enfant.
I'm sorry, I have to interrupt. Alexandra, we are still stuck on the title slide. We need to go into slideshow mode in order to advance the slides.
Yeah, I'm doing that. Let me try something else. How is this?
Vous pouvez utiliser le PDF si le PPT
Ouais,
marche
ouais,
pas.
si jamais ça marche pas, ouais, ouais.
We don't see it
So
yet.
I can't, the problem is that I can't see the chat box or anything else when I'm presenting my screen, unfortunately, which was your problem, Jeanette, you know. Yeah, no, I know. I was hoping somebody would, because I could hear a lot of beeping. How is it now?
You need to screen share. We're not yet seeing it.
Okay. Sorry about that.
There we go. We see it.
Yeah. But so do you see any changes in the slides? Pardon, Dr. Alitanou, on a des problèmes techniques. Est-ce que vous voyez quand je change?
Non, on voit pas en présentateur, quoi.
Oui, je pense que c'est bon, hein?
Press the from current slide button.
Yeah, that's what I did.
Ok, on peut continuer?
Je sais pas. Attends. Est-ce que vous voyez là, je viens de changer de slide. I just changed the slide, sorry. Did you see it?
Non, je ne vois pas.
Okay, I'm going
oui, c'est bon.
C'est
bon maintenant.
Oui, écoute, je vais. I'm gonna share my screen without the presenter mode. I think that's the only way. Can you see this when I change now?
Yes.
Janet?
Yes.
Yeah, tu peux voir?
Yes.
Okay.
Yes.
Okay.
Yes.
So I'll have to do it that way. Really sorry. Continue, Dr. Alitanou. Désolé. Tu veux le prochain slide?
Non, c'est bon ici. On peut rester déjà ici. Ok, donc vraiment désolé pour ce désagrément. Donc je disais tantôt que la stratégie Optima repose sur 3 changements stratégiques. D'abord, l'utilisation du périmètre brachial aussi bien par les familles que par les prestataires de soins dans la surveillance nutritionnelle ainsi que le dépistage en 9 mois et leur monitorage au cours du suivi et la sortie du programme, le tout associé à la recherche des œdèmes et l'utilisation d'un seul aliment thérapeutique pour tous les enfants souffrant de malnutrition aiguë. Ceci semble donner une cohérence à la mise en œuvre des programmes. Enfin, la réduction graduelle du dosage d'aliments thérapeutiques en fonction de la récupération nutritionnelle de l'enfant qui permettrait de faire des économies afin de couvrir plus d'enfants. Et ceci semble aussi mettre en relation rationnel et plus intelligent de cet aliment thérapeutique qui coûte quand même assez cher. Diapo. Slide.
Oui.
Donc, la stratégie Optima a été implémentée dans le Sahel comme en Afrique centrale à travers 4 pilotes opérationnels et 2 essais cliniques, dont un en cours. On envisage également de mettre d'autres essais cliniques et d'autres pilotes dans d'autres contextes. Quels sont les avantages? Cette diapositive ne représente pas des affirmations, mais juste dire qu'avec la mise en œuvre de la stratégie, déjà sur le terrain, les données en cours de finalisation de traitement montrent des résultats très encourageants. Est-ce dit que cette stratégie serait non inférieure à la stratégie standard? Nous pourrons répondre à cette question dans les quelques semaines à venir avec la publication des résultats des essais cliniques, notamment de la RDC. Les principes sur lesquels repose la stratégie ont permis de toucher plus d'enfants. Ceci reflèterait-il un probable élargissement de l'accès au traitement? Je pense qu'avec des enquêtes de couverture à moyen terme, nous pourrons aussi répondre à cette question. Ce qui est certain à ce jour est qu'il a été constaté sur le terrain où la stratégie a été implémentée que les prestataires notent une diminution drastique de la charge de travail accompagnée d'une baisse non négligeable de moyens humains qui étaient utilisés auparavant. Il y a une étude de coût-efficacité qui est actuellement en cours en collaboration avec l'Université de Harvard aux États-Unis pour statuer sur cette question. Diapo. Les facteurs pouvant favoriser cette mise en œuvre de la stratégie optimale, c'est d'abord l'adhésion qu'on a constatée de la communauté, là où ça a été implémenté, qui comprend très bien les tenants et les aboutissants de cette stratégie. Et également l'adhésion des prestataires de soins du fait de la facilité de compréhension et d'orientation de la stratégie optimale. Et surtout, il a été observé que la stratégie est vraiment adaptable à tout contexte. Les possibles obstacles à la mise en œuvre sont les quelques réticences et nous pensons qu'avec la publication très prochainement des résultats de l'essai clinique RDC, nous pouvons solutionner ces réticences. Il faut souligner aussi que la mise en œuvre nécessite quand même des enjeux logistiques afférents à prendre en compte. Diapo. Les prochaines étapes, notamment, sont la mise en œuvre des essais pilotes dans plusieurs contextes, aussi bien en milieu urbain qu'en milieu rural, et des contextes assez particuliers. Nous comptons aussi partager les résultats des études et des publications des articles et profiter, faire une méta-analyse pour consolider les évidences sur la stratégie optimale. Si nous arrivons à faire tout ça, l'autre étape sera de faire des plaidoyers possibles pour les révisions de la malnutrition. C'est tout ce que j'avais à vous présenter ce matin. Je vous remercie.
Thanks a lot for that, Dr. Alitanou. Merci beaucoup. Really sorry about the glitch. Nutritionists are not very well known for their IT skills, so I think I just proved it once again today. Thanks a lot for bearing with that. I see a lot of questions in the question and answer box. It's exciting. So I will ask the questions to our participants. But yes, there's a lot of questions coming. Can't guarantee that we'll be able to answer all of them. I'll make sure that we don't repeat questions, and I will have to translate the questions in French to Dr. Alitanou, so bear with us also about that. But I have a first question for Jeanette and Suve regarding the COMPASS study from Sujay. Hi, Sujay. Asking if there was any difference in terms of height catch-up in standard versus intervention group in the COMPASS study. And also if the RCT checked or evaluated the level of different micronutrient in the control versus intervention group.
Thanks, Alexandra. I will answer these. On the question of height catch-up, we did not look at this in the analyses we've done so far. We're actually starting to look at this more closely now. And so, you know, overall, we don't see major significant differences in really anything that we've looked at, no matter how we break up the data or which indicators we look at. We mostly see very similar results, no matter how we look at the data. But again, we are specifically going to look at this height question, and we have a paper that's just been accepted for publication that's looking at low weight for age, which accounts for some of the stunting, the concurrent wasting and stunting. So that will be interesting. I would recommend looking at that to try to better understand how this protocol might affect other outcomes besides just wasting. On the question of micronutrients, we did not look at that. Again, the goal of the RCT was to see if this protocol was non-inferior in terms of recovery and if it was cost effective. And assessing micronutrients would have been very expensive and time consuming. So we have not looked at that.
Thanks a lot, Janet. There is also a question, I think it's more for Suve with Mali. And if you could explain the reason behind the increase of caseload in Mali.
Sure. So the increase in caseload refers to the increase in Mali. The standard protocol was only for SAM kids. So when you then add an expanded admission criteria until MUAC 125, you do catch more children. So there was an increased caseload at the health facility level with this new protocol.
Thanks, Suvi. So I'll ask a question. There is another question that I will ask to actually all of you. So, Dr. Alitanou, je vais la poser en français après, okay? Mais c'est la même question.
Okay.
So the question is that taking into consideration that MUAC measurement does not allow identifying a large number of SAM children based on weight for height, what is your option for these children missed during the MUAC screening? So that's for Janet, and then I'll ask it in French for Dr. Alitanou.
Okay, thank you. In the COMPASS trial, we also admitted children with a weight for height of -2 and treated them similarly with the COMPASS protocol. They're not in the main analysis. We have another paper coming for the outcomes of these children treated with the combined protocol who had a MUAC. It's a small group. They had a MUAC above 125, but a weight for height less than -2. And I think it was 157 children out of the 2,000 kids admitted in Kenya who fit that criteria. And so that analysis is forthcoming. But I think the first point is that it was a small group in our data set. The next is that, as I mentioned, this weight for age analysis paper coming out from the COMPASS study. Personally, I think this is a very interesting area of work that really integrates the children who are at high risk from a variety of different indicators. So we're looking at, there's the potential to add weight for age less than -3 as an admissions criteria in order to capture children who are, a high number of children who are concurrently wasted and stunted using weight for height criteria less than -2 and height for age less than -2. So a low weight for age is going to capture many of those. And, there's been some analyses done by the wasting stunting technical interest group showing how a weight for age, in addition to MUAC, really captures all near-term mortality. So we're looking at that as an interesting next step because weight for age is more easily used at the community level. It doesn't involve taking height. And when used in combination with MUAC, we can capture a lot of the mortality that would be due to weight for height less than -3, that would be due to wasting stunting, concurrence, or that would be due to low MUAC. So I would just like to advise everybody, do some readings on, there's some great papers that have been written by the Wasting Stunting Technical Interest Group on that.
Thanks, Jeanette. Dr. Alitanou, donc la même question en fait pour toi, mais en français sur ton étude. En considérant que la mesure du MUAC ne permet pas d'identifier un grand nombre d'enfants atteints de masse sur la base du poids pour taille, quelle est l'option dans votre étude pour ces enfants manqués lors du dépistage du MUAC? Tu m'as entendu?
L'évidence que nous avons, oui, très bien. L'évidence que nous avons déjà, c'est que le PB, le périmètre brachial, d'identifier les enfants à plus grand risque de malnutrition, à plus grand risque de décès. Donc, du coup, c'est déjà un acquis d'identifier ces enfants. Maintenant, les quelques enfants, effectivement, qui ne sont pas pris en compte par la mesure du MIAC seront forcément, à un moment donné, récupérés dans le programme.
Oui.
Vous m'entendez?
Oui, oui, oui.
Voilà.
Ok, ok. Merci.
L'étude Optima se base essentiellement sur la mesure du PB et également la prise de poids quotidien et la recherche des œdèmes.
Ok. Docteur Alitanou, je pense qu'il peut-être enlève ta caméra parce que ta voix coupe et peut-être que ça prend de la bande passante. Ouais, je pense que c'est mieux. Merci. Dommage qu'on puisse pas te voir, mais merci. Thanks for that. So another question for Janet, I think, regarding the coverage of treatment, actually, Janet. So one of the main objectives for simplification is actually to increase the coverage of treatment. But the coverage did not increase in the Kenyan, but also there was a South Sudan study of COMPASS that was done. How can you explain this, and why pushing for scale up if the coverage is not improving?
Thank you for this question. I'm happy to address it. In an area, we are putting equal resources into a standard protocol that treats both SAM and MAM, and a combined protocol that treats SAM and MAM. We would not expect an increase in coverage in the intervention. The best we would look for is similarity, so similar coverage, and that's exactly what we found in the COMPASS trial. What you want to look at is coverage in an operational setting when you're comparing a simplified combined protocol against the status quo. And so if your status quo is only treating SAM children in an OTP, then using a simplified combined protocol is going to increase your coverage, hypothetically, because you've now added all the MAM children. And so again, hypothetically, you should be reducing your SAM caseload, which is going to impact your coverage of SAM treatment. So if you're using a simplified combined protocol and comparing it against status quo programming, that's what you want to look at in terms of coverage. And we haven't done that yet. So it's a hypothetical, but there's no reason not to believe that when you're increasing coverage of MAM treatment, that you wouldn't, the assumption would be, yes, you would reduce the caseload of SAM and thus increase the coverage of SAM treatment and MAM treatment. So again, in an RCT, you would not expect to see increased coverage because we are comparing against the gold standard of standard care, which is OTP, SFP, using RUTF, RUSF in the standard protocol in the same location on the same days. And we put equal resources into the standard protocol as the combined protocol. So we saw exactly what we expected to see and hoped to see, which was similar coverage results with overlapping confidence intervals.
Thanks, Janet. So would you say that what's needed then now, because indeed it wasn't very controlled environment, that what we need is to have more bigger scale studies where we actually really look at the coverage to look at improvements in a less controlled environment?
Yes, so that's why we're focusing on operational settings now, and so what we want to look at is coverage and cost effectiveness in operational settings where you're using a simple combined protocol against the status quo, which in many, many cases is MAM treatment not being offered, or MAM treatment being offered in a separate program, or even in a separate location or on a separate day, or using fortified blended flowers. And in any of those situations, you would expect to see an increase in coverage using a simplified combined protocol.
Thanks, Jeanette. Docteur Alitanou, je vais suivre avec toi avec cette question parce que j'avais en fait aussi cette question sur ta présentation. Est-ce que vous avez fait une enquête de couverture pour votre étude?
Non, on n'a pas fait une enquête de couverture. Et comme je le disais dans la présentation, une enquête de couverture à moyen terme nous permettra de répondre effectivement à statuer sur cette question.
Okay. So yeah. Thanks, Dr. Alitanou. That's clear. And another interesting questions, because it's something that comes up very, very often in the discussions about simplified approaches regarding the supply. So I think none of the question will surprise you, Janet. You're ready for all of them. So when treating both MAM and SAM with IUTF, the initial quantity of IUTF needed will increase. So do you consider that this brings a problem in the IUTF supplies, or is this manageable? And do you see that at some point that you treat more children with MAM and fewer children with SAM due to early detection and good compliance or good understanding of the communities?
Yeah, thank you for that question. My answer to this one is often to look at the forest instead of just the trees, because it's similar to the family MUAC approach, where you invest up front to get ahead of the problem. You know, you invest in training mothers and training caretakers, and then over time, you've got a much more efficient and cost-effective system. And so same thing with the simplified combined protocol. You know, part one of this is that our SAM treatment has been optimized. And so, you know, and again, the results are indicating similarity in the way that children with SAM recover under a combined protocol. So you've got less RUTF there because you've optimized the dosage for SAM, and then because you've linked it with MAM treatment in the same protocol in a completely continuous way, over time you would expect to see more, you know, greater proportion of MAM children and less SAM children. That's the goal. Reduce the SAM caseload, because overall cost effectiveness is not just about RUTF, it's also about the associated costs, the systematic medications that are required for treating SAM, the likelihood that a child may need to be hospitalized because they are severely malnourished. So there's a number of things that come into the cost calculation that go beyond just RUTF. So again, in our operational trials, in addition to looking at the coverage that we talked about earlier, we also want to look over time. We want the ability to test this out over, you know, beyond just a year. 6 months or a year it gives us a snapshot, but it doesn't allow us to answer the big questions like these. And so if we can start to implement this over the course of several years, that's when we can assess whether we're reducing the SAM caseload, the associated costs in treating SAM, and seeing a higher proportion of MAM kids, which is a lot less intensive of a protocol. So that would be my answer to that question.
Thanks. We still have a bit of time for more questions, so that's good. We have some questions about relapses, and if relapses were looked at and evaluated during the study. And I'll ask the same to Alitanou as well.
Yes, we recently published in PLOS ONE our results from our relapse study. So we did do a 4-month post-discharge relapse and body composition study in COMPASS. And that slide at the end with all of our publications, maybe there's a way we can make that accessible through the conference, but you can look for it. It's a relapse and body composition study from the COMPASS trial, published in February in PLOS ONE. and we did not see any difference again in relapse or in body composition amongst children treated either with SAM or MAM in the combined protocol or the standard protocol. So again, as I mentioned earlier, every way we slice the data, we still see the same story coming out, which is overall effectiveness, relapse, mortality, etc., is similar across the two treatment arms. But what we're aiming for is improved cost effectiveness and ultimately improved coverage.
Thank you. Docteur Alitanou, est-ce que dans votre étude, j'ai peut-être manqué avec les bips de tous les côtés, est-ce que vous avez regardé les taux de rechute aussi?
Oui, effectivement, les taux de rechute ont constitué un objectif secondaire dans l'étude et nous attendons finaliser complètement les travaux, les résultats et donner des résultats afin de publier les différentes proportions. Donc, c'est effectivement un objectif secondaire de l'étude.
Thanks a lot. Merci beaucoup. I've been asked to wrap up, so I will do so. Really wanted to thank our presenters. Thank you to all of you who put your questions in the chat box. They were excellent questions, and we couldn't cover them all. Sorry about that. We might be able to see with concern if there's something we can do afterwards for the question uncovered. Et merci beaucoup, Dr. Alitanou, pour ta présentation aussi. So we'll take now a short break after this session, and we'll restart in exactly 12 minutes, so at 1:15 for the GMT time. So at 1:15, when you come back, you can choose one of the two sessions that you want to choose. You can go to agenda and information in the conference page, and in the menu on the left-hand side, you're able to select which one you want, and then you can click on join the session that you want to participate in. So thanks a lot for being on this session. There were a lot of attendees and a lot of interest. And we'll see you in about 10 minutes after a short break. Don't forget to hydrate yourself and have some nutritious food. Thanks, everyone.